For me to go to West Haven to meet with the chief of pulmonary disease. And when I got there, he called in the head of the pulmonary laboratory, Dr. Robert Nims. And they looked at me and said, what exactly is it that you do? And I said, well, I was returning the patients to a more normal way of breathing. And they said, well, what is that? And I said, well, if you don't know what normal breathing is, how are you going to know what I do? How are you going to know if I make improvements in that direction? I think this was rather a shock for them as well as for me, because I didn't realize that there was no standard for what correct breathing was. I thought that certainly the medical profession had some idea of knowing if a person was breathing that well or not.
Clinically, physicians taking care of people with pulmonary disease feel that they can do nothing to directly affect the diaphragm. They treat infection of the lungs to minimize the obstruction of air and let the lungs collapse as much as they can and pull the diaphragm up. They don't work directly on the diaphragm.
So that when I got to West Haven, they said, well, now wait a minute here. In order to really have a controlled medical study, you have to have patients that you work with and patients that have other treatment. And for this particular thing, they had picked using intermittent pressure machines. Well, I was rather distressed because, first of all, I couldn't exactly imagine me against the machines. I mean, and secondly, I had known that there was, when pressure was used to breathe, it would tend to throw out everything that I had done. I had found this out with just the pulmonary laboratories. But the study was set up, and the medical profession, I think, wanted these machines to be successful because at that particular time, with all the attention drawn to emphysema, they really had nothing else. Unfortunately for them, within 6 months, although the study was supposed to run 2 years, some of their patients had died, and several of mine were able to go out of the hospital.
These machines actually were a negative factor. They have entirely gone out of use after a study about 15 years ago, a study of many hospitals and probably several hundred patients showing that they did no good.
The test was brought to a close, and a whole series of other things came about. You know, it wasn't until many years later that I realized they were not really doing studies to prove me right. They were doing studies to prove me wrong.
I told Carl in no uncertain words that he was mildly demented, if I may say so, to say that he could affect a rise in the diaphragm and a descent in the ribs. But then, in one patient, we got rather spectacular results showing that he did do this. Now, what this means is that when Carl affects a coordination of all of the groups of breathing muscles and the individual breathing muscles, including the diaphragm and the abdomen and those around the neck and the throat, why the air can flow out of these areas which remain obstructed under every other circumstance. And we have shown that he is able to decrease the volume of the lungs more than any pulmonary man would say was possible. And the function of the diaphragm redeveloped. And Carl refers to this quite correctly as redevelopment or development of the diaphragm. Now, many studies that have been done in the last 5 years have been done at the wrong end of the spectrum. They've studied how forcibly the diaphragm can pull down an inspiration. That's not the important thing. The important thing is what Carl has shown, that the diaphragm can be gotten to relax and go up, to rise, so that during inspiration it can come down. It's got plenty of strength. You don't need to measure the strength.
I also learned about respiratory faults. Now, respiratory fault is an abnormality. I knew it as an abnormality because with the emphysema patients, all their chests were raised and tight, but there is a joint right in the sternum, the breastbone, at the second rib, and it's a cartilage joint and it's for flexibility. But if you use what is called accessory breathing, where you use the muscles of the upper chest and the shoulders and you grab for a breath, you pull on this joint and it lifts the chest on the inhale, and the diaphragm will tend to slip underneath it, and when the diaphragm tries to rise, it will hit the bottom of the rib cage and make the ribs flare. This is called a respiratory fault, and it was thought impossible to reverse it. Once you had it, that was it. Well, of course, that was true if you couldn't redevelop the diaphragm. But as I was able to redevelop the diaphragm, and the diaphragm started going up inside the rib cage started to release around it, and the joint in the sternum became more straight, and even there was possibility to straighten some of the flare at the bottom of the ribs.
So with the inspiration-expiration films, the pneumographs, the cinefluorography, and the Röntgen chirograph, and the vital capacity otherwise, which is a part of what's called spirometry, all showed the same results. Each test confirmed each of the others and demonstrated beyond a shadow of a doubt that the severely damaged lungs of the emphysema patient can in fact exhale the air that the medical profession had been thoroughly convinced was stuck in the lungs, blocked in the lungs, and that the muscles of breathing, all of the muscles of breathing, from those high in the throat, the shoulders, the ribs, the diaphragm, and the abdomen, all can be resynchronized so that the patient can breathe, firstly, with much less oxygen cost in the act of breathing. Fighting against obstruction or fighting against his own discoordination and asynchrony is very costly in terms of oxygen use. But quiet breathing that Carl establishes is much less costly, much more efficient.
Now, of course, the voice was the important thing all the way through. The whole way to redevelop the diaphragm was for the diaphragm to be able to produce enough pressure to make sound without tensing. This was actually what developed the diaphragm. But no one much paid attention to voice, other than my own ear. But here we started getting voices that totally changed as the diaphragm developed.
And we also did cinefluorography, which was taking movies of a fluoroscopic screen. And we showed the movement of the diaphragm and the movement of the ribs, and then projected these on a screen and took tracings of them, and were able to show the synchronization of the lungs and the diaphragm. And that is particularly dramatic because it's very easy for one to see.
These films, owned by the Stough Institute, are the only cinefluorography films of the human diaphragm that exist in medical history. They document how the respiratory system is designed.
What you are seeing here is two X-rays. The one on the right is the inhale, and you can see the lungs are full of air, and the diaphragm, which is the line at the bottom, that is the top of the diaphragm, is sitting very low. On the left, you are seeing the X-ray with the diaphragm now on the exhale stage and rising very high, pushing the air out of the lung. What you saw just a minute ago on the bottom, from the front, the maximum inhale, and on the left, the maximum exhale. The two X-rays at the top are very rarely done, again, because the one on the right is, again, the maximum inhale, and the one on the left, the maximum exhale. Now, what is fascinating here is the difference in the width of the body. When the lungs are full of air, you can see very clearly how it changes the entire shape of the body. And people don't realize how large the lungs are. They think the lungs are right in the front of them, right at the chest. But you see, there's actually more lung tissue at the back than in the front. So here you have maximum excursion of the diaphragm. This is over 12 centimeters of motion. Normal is usually considered around 8, and most people on the street are lucky if they have more than 3. But this is maximum diaphragmatic motion that you're seeing. What you are seeing here has never before been seen. You are actually seeing inside a person's body and seeing the diaphragm rise, which it has done now. In fact, it's off the top of the screen. There it is reflected into the inhale, and now it's rising on the exhale. This again is maximum excursion. This is like the X-rays that you saw previously of over 12 centimeters of motion. The lines that you're seeing crisscrossing are the ribs in the front and the back. There the diaphragm again goes into the inhale, and as you can see, it takes longer for the exhale than the inhale. Now this is relaxed normal breathing for a person whose diaphragm is this strong to have this kind of motion. We'll have the same thing now on the left side. Again, you can see the heart beating, and they move the camera to show you how far that excursion goes. The diaphragm has risen, and we will wait now. There's the next inhale. They move the camera, and you can see how far the diaphragm has descended on the inhale. The motion of the diaphragm is totally the result of its strength. If the diaphragm is weak, as we'll see later, there's very little motion, but this is maximum motion. Now we have an emphysema patient with minimum diaphragmatic motion. And as you can see, the diaphragm is not even clearly defined now. In fact, part of the diaphragm on the side is going down while part near the center is going up. That is called paradoxical motion. And the diaphragm is very diffused. It's not clearly outlined. That is because when the diaphragm weakens, it actually slightly deteriorates. And you can see that it does not have the same. Now the patient is trying to breathe fast, as if he were walking. You can see the diaphragm is just not turning air over at all. So he would be then going into accessory breathing and gasping. You have the same patient now and seeing the diaphragm from the left side. Again, the shadow on the whitey part toward the left top part of the screen is the heartbeat. And again, here the diaphragm is a little more clearly defined than it was on the right side. But you see when he tries to exhale how the diaphragm just sort of flutters. And of course, the minimum turnover of air makes him gasp. Also, if you can see the side, you can see the ribs are going paradoxically as well. That means that rather when the diaphragm is descending on an inhale, the ribs are coming in rather than going out. So everything is backwards. All of this has to be corrected in order for the patient to have relaxed breathing. This is Mr. Cannon when I first got him. He was an advanced emphysema patient. In fact, he was a bed patient. You can see that his breathing is what we call accessory breathing. That is that on every inhale, he is lifting the chest, the shoulders sit high, and when that happens, here we are seeing the neck. The neck tenses on every inhale as he grabs for breath. All of these pictures were taken to show the abnormalities of how the breathing process goes when it is reversed. Here we have the front of the chest, and the chest is pulling on every inhale, and on every exhale, rather than the abdomen contracting, it's expanding, so that he pulls air in at the top and then pushes for the exhale. This picture is showing the same thing from the back ribs, how the back ribs are pulling on each inhale rather than opening, and how at the very bottom, again, there is protrusion on the exhale. We have still Mr. Cannon, and this is the way his diaphragm looked when he was gasping. In other words, he even has a weak spot through it, as you can